The 5 responses in the ACVPU scale are recorded as follows. A is for alert, is the patient alert? C is for confusion, is the patient confused? V is for voice, is the patient responding to your voice? P is for pain, is the patient responding to a pain stimulus? And U is for unresponsive, even to painful stimuli. ACVPU assessment is not a replacement for the Glasgow Coma Scale, which should still be performed after our initial assessment, resuscitation and management. There is significant neurological change between V and P, meaning that the gag reflex may be lost at this point, with obvious implications for airway management, and this will usually require expertise from an anaesthetist. This is especially true in the case of deterioration involving increased intracranial pressure. This section looks at the details of making observations and completing a GCS chart. There are clear guidelines from institutes and professional bodies on the frequency of measurements and when this may be reduced. Always increase the frequency of observations according to agreed guidelines if the patient's condition deteriorates. A fall of 2 points overall or 1 point in motor response indicates significant deterioration. You must report this to senior medical staff and get help. To reduce discrepancies in interpretation, it is recommended that the same practitioner undertakes GCS observations for the duration of the shift. And when there is a handover of care, it is good practice to demonstrate how a score has been generated. Remember that the overall score conveys little meaning, and when communicating GCS scores, it is important to convey the constituent points. For example, eyes 2, voice 3, movement 4, rather than saying GCS is 9. Select each of the links to find out more. If the patient's eyes are open on approach, then he would normally score a 4. If the patient's eyes open only when you speak to him, then he scores a 3. Start speaking in a normal tone of voice before gradually raising your voice. Some patients may respond better to familiar voices. If a painful stimulus is required to initiate eye opening, then the patient scores a 2. If the patient's eyes do not open in response to speech or pain, then he scores a 1. If the patient's eyes are closed for another reason, such as eye injury or swelling, record the letters NT to indicate non-testable. A patient holding a clear and orientated conversation or able to answer questions such as, "Who are you?" or "What is the year and month?" would score 5. Confused statements in response to these questions would score a 4. Try to orientate confused patients by encouraging them to remember for next time. Loss of orientation to time, place and person in a deteriorating patient tends to happen in that order. Inappropriate words in response to simple questions scores a 3. This may take the form of a stream of obscenities, or the patient may well repeat himself at great length. Moaning, grunting, or other indistinguishable sounds scores a 2. A score of 1 is reserved for a patient who makes no verbal response. If the patient is orally intubated or has a tracheostomy, or if the patient is dysphasic, record the letters NT for non-testable. Obeying clear commands scores a 6. These should be at least 2 different clear instructions, such as "stick your tongue out," or "show your teeth," or "give me a thumbs up." Localizing to pain scores a 5. This would normally be seen as the patient moving his arm towards a source of pain and trying to remove it. Flexion to pain scores a 4 if the patient bends his arm but fails to locate the source of pain. Abnormal flexion to pain, as shown, is known as decorticate posturing and is most often seen as arm bending while the stimulus is present. It tends to be a slower response to pain and scores 3. Extension to pain is known as decerebrate posturing and scores a 2. No motor response at all scores a 1. Remember that gripping is a primitive reflex action and tells us nothing about motor function. Often as intracranial pressure rises, blood pressure also rises. Typically, systolic hypertension develops combined with a widened pulse pressure, that is, the difference between the systolic and diastolic blood pressure. Often patients who have a head injury or significant intracranial pathology will have a rise in blood pressure as the body tries to maintain cerebral perfusion. For patients who present in a hypertensive state, increasing the blood pressure to attempt to maintain cerebral perfusion should be considered. The pulse should be evaluated for rate, rhythm, and regularity. A pulse rate dropping into marked bradycardia along with hypertension often indicates increasing intracranial pressure. Respiration should be evaluated for rate, rhythm, and regularity. Irregular breathing, such as Cheyne-Stokes patterns, cluster breathing, and hyperventilation may be seen. A combination of hypertension, bradycardia, and irregular respiration is known as Cushing's triad, and may indicate critical intracranial pressure. Pupil reaction has already been covered in the earlier section on observations. Remember that limb movement should always be assessed in the context of other injuries and pre-existing conditions. Although we would never normally deliberately inflict pain on a patient, we need to balance this against the need to establish the patient's condition to prevent further harm. Each of the following techniques involves applying increasing pressure over about 30 seconds, but must be used only when the patient does not respond to verbal stimuli. The trapezius muscle squeeze is a simple squeeze of the trapezius muscle between thumb and fingers. This is considered the safest way of eliciting a response to pain. Supraorbital pressure involves applying pressure to a notch below the level of the eyebrow. This should be used only by a trained practitioner and should never be used in the presence of eye injury or facial or skull fracture. Jaw margin pressure involves applying pressure to the angle of the jaw in a similar way to the jaw thrust maneuver used for clearing an airway. Other techniques such as sternal rubs can cause significant bruising, and nail bed pressure are not favored as they can elicit simple peripheral reflexes.